Thank you for inviting me. So I'm going to talk about preventing obesity-driven endometrial cancer. So as it is here in Australia and New Zealand, endometrial cancer is really common in the UK. In fact, it's the fourth most common cancer affecting women. The incident rates have been rising over the past 20 years, such that in 2018 there were 9,700 new cases in the UK. Deaths are also up, mostly as a consequence of the increasing incidence of the disease. And despite all of that, womb cancer, as we would like to call it to public and the patients, it's often a diagnosis that you've never heard of until you are yourself diagnosed with it. So there's a complete lack of awareness, which can lead to delayed presentation. So endometrial cancer links most closely with obesity of all the obesity-driven cancers. We carried out one of the first systematic reviews and meta-analyses that looked at the prevalence of endometrial cancer with obesity. So we looked at 24 studies and over 17,000 cases, and were able to show that all of the studies, irrespective of the population that it studied, showed a very strong association between endometrial cancer and obesity. And many further systematic reviews and meta-analyses have been carried out since then, and essentially confirm that not only is obesity a major risk factor for endometrial cancer, but also there appears to be a dose-dependent response, such that with every 5 kilogram per meter squared increase in BMI, the risk of endometrial cancer increases by around 60%. And that means that at a BMI of 42, a woman has a near 10-fold increased risk of endometrial cancer compared with her normal weight counterparts. And to put that into some sort of context, that means that the lifetime risk of endometrial cancer in a woman with a BMI over 40 is around 10 to 15%. And that's not dissimilar from the lifetime risk of lung cancer in lifelong smokers and heavy smokers. And indeed, it's been estimated that around 35%, if not more, of all endometrial cancers are directly attributable to obesity. And this is obviously important because the UK is putting on weight much like many other nations. So in England, the prevalence of obesity in women rose from 16% in 1993 to around 29% in 2019. In 2019, an estimated 6.6 million women had a BMI greater than 30 kilogram per meter squared, and a further 7.2 million had a BMI greater than 25 kilogram per meter squared. So around 60% of all women in the UK are classified as having overweight or obesity. Obviously, the prevalence of obesity increases with age, and there are regional differences in the UK according to socioeconomic deprivation. So obesity is very closely linked with socioeconomic deprivation. And of course, it's not just a problem in the UK, it's a problem all over the world, such that the prevalence of obesity and overweight is becoming of pandemic proportions. And indeed, it's this toxic combination of the obesity epidemic and fewer hysterectomies for benign gynecological diseases that means that we are now having an emerging epidemic of endometrial cancer. And it's been estimated that in the States, by 2030, endometrial cancer will surpass lung and colorectal cancer as top causes of cancer in women. So what can we do about it? Well, I think if we can understand the mechanism underpinning the link between obesity and endometrial cancer, we might be able to use that knowledge to develop novel prevention and treatment strategies. But of course, prevention studies are extremely challenging. So in a treatment trial, recurrence or death are really the only meaningful clinical endpoints. And a treatment trial would require hundreds of women followed up over maybe 5 or 10 years to show that treatment A adds something over treatment B. But of course, in the prevention setting, we would require thousands of women followed up over many, many years if prevention of endometrial cancer was the endpoint. And clearly this is wasteful, expensive, inefficient, and some might even argue unethical if there isn't good, robust data to support the use of whatever prevention intervention we're studying. So clearly we need some surrogate biomarkers to do our prevention studies. And I think if we can understand how endometrial cancer develops, then we can perhaps identify pre-malignant precursors that precede the malignant endometrial cancer and that could serve as surrogate endpoints in our prevention trials. So atypical hyperplasia is a really good example of this. We know it precedes obesity-driven endometrial cancer. Indeed, it coexists with grade 1 endometrial cancer in a lot of hysterectomy specimens, and there is difficulty even distinguishing it from a grade 1 cancer from endometrial sampling. But there may even be molecular changes that precede atypical hyperplasia. So in a morphologically normal endometrium, there may be molecular changes that signal a high-risk endometrium. And if we can identify these, then we may be able to look and see how good our novel interventions are at preventing or reversing these molecular changes, and that might give us some confidence to go forward to a large-scale prevention trial. And so we've heard a bit about Ki67 yesterday, and this is a good example of a molecular biomarker that could serve as a surrogate marker for endometrial cancer. So Ki67 is a nuclear protein that is only expressed by actively proliferating cells. So in the benign postmenopausal endometrium, the endometrium's pretty quiescent. There's not much Ki67 activity. But as you progress to a proliferating endometrium through atypical hyperplasia, through grade 1, grade 2, and grade 3 endometrial cancer, so you see increasing expression of Ki67. And we did some works really optimizing the scoring and expression of Ki67 for this purpose. And we found that you really need to use whole slides. So TMAs aren't good enough because of the heterogeneity that you see in a sample, and that you need to really use some sort of computer-defined algorithm to count your Ki67 expression because there's such massive inter-observer variability. And so using the Definian software, we were able to show this association between cancer and prognosis and Ki67 expression. So how does obesity cause endometrial cancer? Well, obesity is a toxic pro-inflammatory state of estrogen and insulin excess, both of which act on the endometrium and cause it to proliferate. And as I've mentioned, we can measure that using Ki67 expression. So I'm going to talk about some of the work that we've been doing in Manchester, looking at 3 interventions to try and find a signal for these interventions being useful for endometrial cancer prevention. So these are weight loss, which obviously reduces the aromatization of androgens to estrogen and improves insulin resistance. Metformin, which is an insulin sensitizer and also a weak mTOR inhibitor, mTOR being one of the signaling pathways that is upregulated in obesity-driven endometrial cancer. And of course, the Mirena coil, which is a progestogen-laden intrauterine device that sits within the endometrial cavity and antagonizes the effects of estrogen. So I'm going to tell you first about our study looking at the effects of obesity and weight loss. So clearly, achieving weight loss is very challenging, particularly when people reach a very high BMI. So achieving the weight loss required to bring the BMI down to a normal BMI is incredibly challenging, and then maintaining that weight loss is also extremely challenging. However, we know that bariatric surgery does do that. So bariatric surgery is effective, not just at getting rid of excess body weight, but also maintaining that weight loss for a prolonged period of time. So we obviously can't be using bariatric surgery as a public health intervention, but we wondered whether or not the bariatric surgery model could be useful to serve as a model of what happens to the endometrium when people with obesity lose weight. And so we carried out this prospective observational study where women who were referred for obesity management with a BMI of greater than 35 kilogram per meter squared were offered bariatric surgery or offered low-calorie diet. So this was not a randomized controlled trial. We didn't assign people to one of the two different weight loss regimens, but this was the clinical management that the physicians that they saw thought was the right thing for them. So we took an endometrial biopsy and blood samples at baseline when they were referred to the obesity service, and then we took samples at 2 months, which in the bariatric surgery group, the women will have lost around 10 to 15% of their excess body weight by 2 months, and then at 12 months when they had lost up to 60% of their excess body weight. And then in the group that underwent just a low-calorie diet, we undertook the same time points of sampling, but recognizing that they would lose much less weight by 2 months and that it may be poorly sustained by 12 months. And this is what we found. So this is the group. There were 80 women who underwent sampling at baseline, and you can see that the age of the women who underwent bariatric surgery was 43, and those that underwent a diet was 46. That the BMI was higher in the group that had bariatric surgery, so as I said, it was physician choice with the patient deciding what type of management they'd have for their obesity than those who underwent the diet, and their median weights were 137 and 111. And what was particularly interesting was that in these 80 baseline biopsies, we found 4 grade 1, stage 1A endometrial cancers and 6 atypical endometrial hyperplasias. So these were in women who had not attended a doctor to say that they were having any symptoms or any abnormal bleeding. So this was just sampling on the day of their referral for weight loss management. So that gave us a baseline prevalence of an abnormal endometrium in this apparently asymptomatic population of around 12%. What was really interesting, obviously we managed these women with endometrial cancer by offering them a hysterectomy, but those with atypical hyperplasia had repeat biopsies at 2 months as per the protocol, and 4 of the 6 had resolved. We didn't quite believe it and continued to take biopsies every 3 months to check for recurrence of their atypical hyperplasia, but they didn't recur. These were all women who were in the bariatric surgery arm and lost weight and continued to maintain their weight loss. The other 2 had a Mirena, and they underwent resolution of their endometrial abnormality as well. We also saw molecular changes in the endometrium with weight loss. So we saw a reduction in Ki67 by 2 months that was sustained out till 12 months. And we saw reductions in, massive changes in circulating hormones and in their insulin resistance markers, and also in systemic inflammatory markers, as shown here. And what was really interesting was that these changes preceded weight loss to some extent. I mean, they had lost some weight here, but not as much as they had lost by 12 months. But we saw profound changes even at 2 months. So possibly as a consequence of the metabolic effects of that bariatric surgery. We also saw, we saw a reduction in Ki67 expression. We saw a reduction in the phosphorylation of AKT. So this is one of the mTOR pathway molecules that's thought to be important in obesity-driven endometrial cancer. So we saw less expression of the activated phosphorylated form of AKT with weight loss. And we saw loss of glandular P10 at baseline. So P10 is a tumor suppressor protein of a tumor suppressor gene that protects the endometrium, and its loss suggests that it is indeed a high-risk endometrium that is prone to developing cancerous changes, and we saw expression of it with weight loss. And we also saw profound changes in the immune microenvironment with weight loss. So we saw an increase in the number of CD8 positive T cells between baseline and 12 months following weight loss, suggesting that these T cells may be important in maintaining endometrial health in lean women. So we've now paired up with Mark Gunter and Laura Dosas from IARC and Imperial College as one of the teams for the CRUK funded Cancer Grand Challenge, Prominent. So this is a £25 million CRUK grant where we are essentially repeating this study, but not just collecting endometrium, also collecting breast tissue, colorectal tissue, spit, buccal cells, blood, urine, feces, swabs, and so on, and then using loads of really state-of-the-art technologies to try and interrogate these specimens before and after weight loss. So watch this space. So what does this study show? I mean, essentially, we're seeing a really high prevalence of occult, atypical hyperplasia and endometrial cancer in women referred for obesity management, and begs the question of whether we should be screening women based on BMI for endometrial abnormalities. We saw weight loss was associated with changes in the endometrium, possibly showing a shift or a transition from a high-risk to a low-risk endometrium, even in those that were morphologically normal. So obviously we would like to expand this beyond the bariatric surgery model because that's not something that we can offer to everybody. And we wondered whether or not women would be compliant with a low-calorie diet for the purposes of endometrial cancer prevention. And so we carried out a randomized controlled trial of weight loss achieved through total dietary replacement with a very low-calorie milkshake diet in the first group, and the second group underwent a surveillance period followed by the same weight loss program. And we wanted to see whether we saw the same molecular changes in the endometrium, but also in breast associated with weight loss. And we're still looking at those data now. So on to the second intervention that I want to talk about. So we first became interested in metformin as a potential prevention intervention for endometrial cancer when metformin hit the headlines with headlines like this, that essentially people with diabetes who were taking metformin had a reduced incidence of cancer compared to those who weren't taking metformin, and also reduced mortality associated with that cancer. And then there had been some studies looking at people receiving neoadjuvant chemotherapy for breast cancer, and the people who were diabetic and were taking metformin were more likely to show a complete pathological response than those who weren't taking metformin. And so we wanted to see if there was any indication that we could see something similar in endometrial cancer. And so we carried out this pre-surgical window study where essentially we offered women metformin taken twice a day, high doses, or a placebo in the 2 to 4 week pre-surgical window period between diagnosis and hysterectomy. And we took a biopsy at the time of randomization, and then a biopsy again at hysterectomy, and compared the expression of Ki67 and some of these other molecules that I've talked about. And in the sort of pilot study that just looked at metformin, we saw a reduction in Ki67 associated with pre-surgical metformin. But unfortunately, in the placebo-controlled trial, we no longer saw that signal. So there was no difference in the Ki67 expression rate associated with taking metformin during this pre-surgical window. So it might just be that the duration of treatment is too low for us to see a signal. But it really highlighted the need for a placebo group, even in a window study, because the reduction that we had seen in the pilot study was a consequence of the way that the endometrium was sampled before and after the metformin. So here by Pipel, and here from the hysterectomy specimen. And so when we directly compared with a placebo group, we were able to show that that reduction was there, irrespective of whether they'd had metformin or placebo. So then on to the final thing that I want to talk about today, which is obviously the Mirena coil. So we know that Mirenas are effective in managing atypical hyperplasia and possibly in around 50% of grade 1, stage 1A endometrial cancers. But they take a really long time. It takes a really long time to work. So I know in the FEM study, the treatment window was 6 months, but in the UK, we've been using a 12-month treatment window. And we know that once we stop treatment, recurrence is really common, perhaps 20 25 to 40% of people will recur, and we currently don't know at the point of starting treatment who we should recommend treatment for because we don't have very good predictive biomarkers. And we wondered whether weight loss achieved during the Mirena treatment window could help with this effectiveness of this treatment. So clearly weight loss in the context of a person diagnosed with atypical hyperplasia or endometrial cancer is really important for all of the kind of wider health reasons. But if they are wanting to keep their uterus for fertility-sparing reasons, then losing weight is going to be helpful in terms of achieving a pregnancy or being enabled to undergo assisted reproduction. Even if they don't manage to clear their endometrial abnormality, losing some weight could make them more suitable for a laparoscopic hysterectomy, less likely to have a conversion to an open procedure, and to make it more safe kind of perioperative period for them. We wondered whether if they lost weight during the Mirena treatment window and they showed a clinically effective response to the Mirena, whether when we then took the Mirena out, they'd have a reduced risk of recurrence. And we wondered whether it might help to improve the response to the progestin. So we carried out the Mirena study. Essentially in this study, women who either wanted to keep their uterus for fertility-sparing reasons or who were unwilling or unfit for surgery had a Mirena put in if they had atypical hyperplasia or a grade 1, stage 1A endometrial cancer. And they were offered bariatric surgery if their BMI was greater than 35 kilograms per meter squared. So again, this wasn't an intervention study. This was offering them bariatric surgery and seeing who would accept it. And essentially, only 30% of people would accept bariatric surgery in this context. And this was despite really explaining how unlikely it was that they would be able to achieve massive weight loss and sustain it in the long term without it. People had very fixed views about whether bariatric surgery was something that they would have. So the ones who agreed to bariatric surgery were referred for expedited bariatric surgery, which was carried out between 6 and 3 months after their endometrial cancer diagnosis. And those who didn't want to have bariatric surgery were encouraged to lose weight through a low-calorie diet. So if we just include the ones who had a BMI over 35, then we had 77 participants whose median age was 58, really reflecting these inclusion criteria, with there being more who were unwilling and unfit for surgery than those who wanted fertility-sparing management, with their median BMI at starting point of 48. And unexpectedly, we showed that weight loss in the bariatric surgery group at 12 months was much greater than in the diet group, although I did manage to enable some people to lose weight by low-calorie diet just by encouraging them and weighing them at every clinic visit. So I was quite proud about that. But what was really important and very interesting from our perspective was that those who lost more than 10% of their total body weight, either by bariatric surgery or diet, were 4 times more likely to respond to the Mirena than women who did not. So we also looked at whether we could find any predictive biomarkers to enable us to choose people for this treatment better, and we found that those who didn't respond had a higher baseline HE4, serum HE4 level than those who did respond. And really the only things that predicted Mirena treatment failure were a high serum HE4, endometrial cancer as opposed to atypical hyperplasia, and actually we saw a signal with older age, so that the younger women were more likely to respond than the older women. So this really just shows, as has been shown in the literature, that progestin treatment can reverse atypical hyperplasia and some endometrial cancers. And I think it's really important to use the Mirena treatment window to address the risk factors. There's no point in managing somebody with a Mirena if we don't address the risk factors during that 12 months. So that's encouraging them to lose weight and considering workup for fertility if that's the reason that they're having the Mirena for. But bariatric surgery may be suitable for selected patients, but also a supervised dietary caloric restriction may also work, suggesting that this diagnosis of endometrial cancer could serve as a kind of teachable moment, if you will, encouraging them to lose weight. But really excitingly, weight loss during the Mirena treatment window may improve response to progestin therapy, and HE4 is a promising biomarker for progestin treatment response. So clearly what we want to move towards is primary prevention. So we wanted to know whether women with obesity recognize themselves as being at risk of endometrial cancer and whether they would consider having a Mirena coil placed simply for endometrial cancer prevention. And so we carried out this study called the PROTECT study, where we asked women to take part. So we screened them and carried out a weight loss questionnaire at baseline. Then 8 weeks later, we took a biopsy here, we took a repeat biopsy here after no intervention, and then we placed the Mirena coil and took a further biopsy at 6 months, so that we had biopsies either side of the no treatment window and then biopsies either side of the intervention window. And essentially this shows that such a study could be possible. So there were 104 women invited to take part. 54 were eligible, 35 consented, and 25 eventually received the Mirena. So if we were to do a bigger study of this, then we would clearly need around 4 times, to approach around 4 times the number of people that eventually took part. Of the 24 of the 25 kept their Mirena in and actually noticed an improvement in their menstrual function and quality of life. And again, we saw this reduction in Key 67 during the Mirena treatment window. We're now doing a study called EndoCare, which is a pre-surgical window study looking at whether a low-energy, nutritionally complete total diet replacement given, given during the pre-surgical window period between diagnosis and hysterectomy can improve outcomes. So essentially we're looking to see, is this a feasible thing that we can do? Can we achieve weight loss during that pre-surgical window period? And does it reduce post-operative complications, we're ultimately with a view to seeing whether it can improve oncological outcomes. So this study, EndoCare, has just started in the UK. It's a multi-centre study, a feasibility study with just 72 women, but very exciting to see what that shows. So finally then, who should we be targeting for prevention? Now, listening to some of the talks yesterday, I think we need to be looking at even younger women here. But in the UK, we thought that this is the kind of age at which we might be considering endometrial cancer prevention interventions, because it's likely that they will have completed their families by then and be willing to undergo treatment with a Mirena, for example. But we'd like to consider doing a randomized control trial using a high-risk endometrial or atypical hyperplasia as our surrogate endpoints for endometrial cancer. And then essentially we've devised a risk prediction model that combines all the different risk factors that we know about to include an obesity score, a reproductive score, and an insulin resistance score to categorize people as low risk, intermediate, and high risk. And the idea is that we would approach these women to see if they would take part in a randomized controlled trial of endometrial cancer prevention. Ultimately, we'd like a really much more sophisticated genetic score than we currently have in our model, and we have been working in this space looking at whether or not there are polygenic risk scores that can predict endometrial cancer that could eventually find their way into such risk prediction models. How do women feel about taking part in prevention intervention trials? We approached 74 women with a median BMI of 47 and a median age of 51, perhaps about the age that we'd be considering approaching them for such a study in the UK. And we found that women did appear to be quite amenable to these interventions, saying that they would be happy to lose weight, eat healthily, and exercise more just for endometrial cancer prevention. They might be willing to take a pill every day if that reduced their risk, but only around half were interested in a Mirena purely for prevention interventions. And that is consistent with what we saw in the PROTECT study. In terms of what the barriers were, things like the cost of eating healthily and exercising, forgetting to do so, willpower, physical fitness, social anxiety, possible side effects. And previous bad experiences was really important for this Mirena problem, whether or not a person was interested in a Mirena for endometrial cancer prevention, often citing their friends, their family of having had previous bad experiences with a coil. And of course, this is something that would need working on. So, in conclusion, these are really difficult studies to do, but I firmly believe that we cannot let that put us off, because defining an at-risk signature, how does obesity cause endometrial cancer, and do lifestyle changes, including weight loss, improve outcomes in endometrial cancer, were all within the top 10 most important unanswered research questions in endometrial cancer, according to patients, their carers, and clinicians in our James Lind Alliance Priority Setting Partnership that we published nearly 10 years ago. So, it's time for action. Endometrial cancer is increasing in incidence, not just in the UK, but all around the world, and I've been hearing about the problem that it is here too. And if we can understand the drivers underpinning endometrial cancer, then we might be able to design smart prevention studies, but clearly we need to act now to prevent the emerging epidemic of endometrial cancer. And with that, I'd like to thank you very much for your attention.